But anyhow, the title of the project is HyperPET, a novel multi-parametric imaging platform for patients with neuroendocrine tumors. Matthias, please.
Yeah, thank you very much for allowing me to present my project here. It's called HyperPET, which is a novel multi-parametric imaging platform for patients with neuroendocrine neoplasms. HyperPET is, as the word says, is a combined imaging modality taking the best from positron emission tomography imaging and magnetic resonance to non-invasively visualize glucose metabolism in vivo. And this is particularly interesting for patients with neuroendocrine neoplasms. As you know, neuroendocrine neoplasms is a highly heterogeneous class of disease, and the prognosis for patients is highly variable. And grading is performed according to biopsies or surgical specimens according to the WHO classification. And many patients show both within tumor and between tumor heterogeneity, and also the grading has a tendency for some patients at least to progress over time. So it's difficult to always get a precise and fully up-to-date disease status for the individual patient. And this is particularly true if the patient has multiple neoplasms, like the one we see on the right. And here we can use positron emission tomography or PET imaging to overcome some of these challenges, as the imaging represents a whole body view of the patient and the entire tumor burden at once. And then you eliminate any sampling error and allow for also repeated analysis of the patient's disease stages over time. In particular, PET imaging with the radio-labeled glucose analog FDG has proven particularly interesting for determining the prognosis for patients with NEN. And in my group or other people have previously shown that patients with a negative FDG PET, that is a scan where no tumors show FDG uptake, has a better prognosis than the patients that have a positive FDG scan, meaning that there is at least one tumor that shows FDG uptake. And this is shown here on the graph, where you have the blue curve representing an FDG negative group of patients and the green curve representing patients with positive or uptake of FDG, and there's a clear difference in overall survival for these two. And crucially, this dichotomization works also within the different WHO grading classification, as simplified here for a patient with, or two different patients, both with G2. Top one has a Ki-67 proliferation index of 14%, but is FDG negative and is still alive at follow-up 73 months later, and essentially following the blue curve. Whereas another patient with a G2 and then with a Ki-67 proliferation index of 5%, but FDG positive, scan died only 18 months later. So in essence, you have a pretty strong prognostic marker of overall survival. But we'll dig a bit into what actually is seen on the PET and what it represents. So what we see in the scan is actually one of the cancer hallmarks that Eva mentioned in the first presentation, that is the altered cellular glucose metabolism that is seen in many cancers. And seen here is the healthy cell metabolism of glucose, shown on the left, goes through the oxidative phosphorylation that happens in the mitochondria, going through the intermediate glucose derivative pyruvate. And this process is very effectively yielding a lot of energy per mole of glucose. But in cancer cells, that's shown here on the right, there's a shift towards glucose metabolism through glycolysis with production of lactate. And this happens even in the presence of oxygen. And this ATP yield or energy yield is much lower, so the cancer cell requires a large amount of energy and a large amount of glucose to stay alive. And this is what we actually see on the PET scan. And this shift is an old effect determined many years ago, actually, called the Warburg effect, and is considered the true malignant driver of the increased glucose consumption seen in cancer cells. And with FDG, we visualize this cancer cells, or the glucose metabolism through this radio-labeled FDG. And the FDG molecules are taken up by the cell like normal glucose, but however, once they're phosphorylated inside the cell, they cannot be further metabolized, and also they cannot exit the cell again. And in this way, we do not know what happens to the FDG after it enters the cell, so we can't really tell what happens to the glucose also. And in particular, we don't know if they go through oxidative phosphorylation or is metabolized further through the Warburg effect and into lactate. So from the FDG PET, we only get the total glucose consumption, so to speak. And what we're really interested in is the Warburg effect, that is the production of lactate from pyruvate that happens inside the cell. And so we would expect that if we could see this better or more directly, we get a more precise knowledge of what actually goes on inside the cell, and potentially in the future give a more precise prognosis. But unfortunately, we cannot see this with PET. At least to my knowledge, there are no markers that allows us to do so. But if we turn to another imaging modality, the magnetic resonance, then it has recently become possible to actually study this transformation of pyruvate into lactate inside the body. However, for this to work, then the pyruvate molecule has to be processed before it's injected into the patient. And this is done in a machine called SpinLab that is essentially a very, very expensive and very, very cold microwave operating at minus 272 degrees, so almost at the perfect zero level. And then this microwave is placed inside a large magnet. And this then allows the hyperpolarized or the pyruvate to become hyperpolarized or hypermagnetized in a sense such that it can be detected by the MR scanner. So when this hyperpolarized pyruvate is injected into the patient and the patient is placed inside the scanner, then the pyruvate compound has a specific signal that can be detected with a specific MR technique called MR spectroscopy. And importantly, when the pyruvate is turned into lactate, you can still see this signal, but it's located somewhere else in the spectrum, and then you can separate these two, and you can actually quantify the amount of lactate that is produced in real time and non-invasively. And also, even more importantly probably, is that you can spatially localize this inside the patient so that you can generate pyruvate and lactate maps, so to speak, where you show high and low uptake of lactate and pyruvate. And this is exemplified here for a patient with a brain tumor that we have on top the anatomical scan showing the tumor in the green circle, and in the middle one you see the signal from the pyruvate that is located to most of the gray matter. But on the bottom one we see the actual lactate buildup that only occurs inside the tumor. So here we can see the specific Warburg effect going on, but what we can see is the total glucose consumption of the cell that we get from FDG PET. And we think that it will be particularly interesting to see how this ratio between total glucose consumption and the Warburg effect differs for different tumor types and also across tumor aggressiveness, in particular in neuroendocrine tumors. So in order to do this and get these ratios, we intend to combine the best of two worlds, so to speak, from the PET and the MR, to get both the total glucose consumption for PET and the hyperpolarized production of lactate from the MR. And we do this by combining the two modalities in a PET-MR scanner, and this has been termed then hyperPET. And so far, only preclinical studies of hyperPET have been performed, and primarily on spontaneous tumors in dogs. And here, there's an example of a hyperPET scan of a sarcoma in a dog leg. And on the left is the anatomical MR scan that shows a tumor on the left, and then you have the muscle on the right. And this muscle was actually right before the dog was anesthetized for the scan, and therefore there was also glucose uptake, as you can see from the FDG PET, in the muscle, but also in the tumor as expected. But turning to the lactate signal on the right, you see only specific buildup of lactate in the tumor and not in the muscle, essentially showing that you only see buildup from the Warburg signal, Warburg effect, and not the oxidative phosphorylation that goes on in the muscle. So a clear illustration of the specificity of the method, so to speak. Yeah, as I said, only preclinical animal studies so far, but we're finalizing the process of moving this method into patients, and are particularly focused on the patients with NEN because of the dichotomization I showed in the beginning. So it's interesting to see high-low effects. And as a first step, we'll perform a feasibility study, including 10 patients, to work as a proof of concept. And what we hope to gain from this is, of course, on the basic science level to get a more detailed or refined phenotypical characterization of the individual NAND tumors and particularly show these different ratios between the total glucose consumption and lactate production and get sort of like a malignant glucolytic fingerprint of the individual tumor. And on the longer term, we expect to and hopefully get a more refined differentiation of patients than what we can get with FDG alone. So in essence, hopefully turning this dichotomized graph into something where you can refine the FDG positive scans even further. So have like a negative or positive Warburg effects showing that we would think that the patients with a positive Warburg effect would perform worse than ones with the negative one. Of course, this requires a lot more than 10 patients, so this is just an initial feasibility study to work as a proof of concept that will pave the way for a larger study that in the future. And this, importantly, also hyperpet is not restricted to cancer or to NAND patients, also other cancer types, and you can trade the tracers between other tracers than FDG. Yeah, I think that's all I have to say, and I think my time is up.
Thank you, Matthias. Yeah. That was interesting. Is it expensive, the equipment you have to use for this?
Yeah, it's really expensive. So that's also what we're working on in Copenhagen to make it a bit less expensive than when you go out and buy it directly, and that takes some time and it's difficult work, but we think we're getting there. Because that's, of course, it's not a primary diagnostic tool for every patient who comes to the door as it is now.
Yes. Any more questions, people?
Can I have a question?
Of course.
Matthias, thank you. Very interesting work. I am curious about, are you planning to compare the mitochondrial density in the tumors that you are planning to investigate or with this type, with hyperpet? After surgery, probably.
Yeah, I mean, we first of all, we want to look at markers that are enzymatic markers that are involved in different processes, both in the lactate production and also in the oxidative phosphorylation and glucose transporters. But mitochondrial density would be a good idea, because that could be, in essence, it could just be that they don't have any mitochondrials left or something like that, that they're forced to go through another process to generate energy. Good idea.
Because mitochondrial density is, in several studies, it is related to a response to chemotherapy. I mean, it is very interesting if you can put the density in the tumors in relation to their metabolism. This is a very good job.
Thank you.
Jag har en fråga också. Jag undrar, det är väl fortfarande, sorry, English.
Yeah.
I have a question.
Yeah.
It is still with spectroscopy that you have to manually position the voxel in the tumor.
Yeah, you have a field of view, so it's not, at this point, it's not a whole body imaging. It's not possible, but you get a larger field of view of what you actually get. So you would have to pick out tumors.
Yes.
That you want to study, but I mean, it could be, if you would usually go through having maybe an FDG positive scan in advance, and then you could selectively pick out the ones that have a positive FDG and then differentiate between those.
What is the typical voxel size today that you need?
Voxel size, you can get a field of view of up to 25 times 25 usually. That's and then 5 centimeters thickness, but it depends. There's a lot of technology. I'm not so much into the actual technology, but you get a voxel size of roughly 1 centimeter, 1 cubic centimeter.
Yeah. Okay.
So not smaller than that. That's but there's a lot of improvement going on in the radiology department on getting new sequences and optimizing, because the good thing about this is that you get vast hyperpolarizations. You have excess amounts, so you can really sort of undersample a lot and still gain a lot of info with a lot of undersampling that wouldn't have worked at all if you hadn't done this hyperpolarization.
So how do you decide if you have a positive spectroscopy or negative? What is the cutoff?
Yeah. Of course, that would have to be established, and maybe there is no cutoff. Maybe, but you get different, sort of like an SUV max. You can get a surrogate marker for when you do different kinetic models. So you can get an idea of how fast is the rate of lactate production. But of course, you would have to do a large study in order to get this. Plus minus, and it might not even be plus minus. It could be a gradual response in some way. But it's interesting because for the FDG, it really is all or nothing, so to speak, where you get really either it's turned on or it's not turned off, or turned off or on, where it could be that this is more graded. But that would be interesting to investigate.
Yeah. Thanks.
Thank you, Matthias.
Yeah.
We move on. And the last